Ruthless Compassion is a podcast that shows you how to become fiercely kind. I'm the host, Dr. Marcia Sirota, and in each episode, I get into it with experts and regular folks about the things that get in the way of what we want. Things like addiction and mental health, isolation and loneliness, difficult family and work relationships, and the importance of self-care. I want to help you overcome the obstacles to living your best life, and I want to inspire you to become a powerful kindness warrior. Welcome, Dr. Michael Kaufmann, to the Ruthless Compassion podcast.
Thank you. Pleasure to be here.
Yeah, it's really great to have you here. And I'm very interested in your take on addiction because you come to it from, as they say on CBC, both sides of the gurney. And I'm very interested in, basically your life and how you got from point A to point B to point C. So maybe before we begin, you can give a little thumbnail autobiography of yourself for the listener to give them a little sense of who you are and what you've been doing.
Oh, gosh. A thumbnail. Well, I was born in Montreal, suburban Montreal, in the Anglophone enclave and Christian community as a Jewish boy, all by myself and feeling quite different for that reason. Anyway, I grew up there in what I would call, and always used to call, a fairly normal childhood until I figured out later on that it really wasn't, if there is such a thing. It certainly had its moments of challenge and its moments of beauty. And only much later I understood how it predisposed me, let's say, or brought risk into my life to develop a substance use disorder, which did appear much later. Anyway, I was a great student, high school, on to university. I studied science and chemistry until I decided that wasn't nearly juicy enough for me. It was much too dry. Be careful what you wish for. I applied to medical school and got in. Had a great few years in Toronto in my medical training and then my family practice residency. I chose family practice because I liked it all. I was a wannabe everything. And so family practice was my choice. And then because I couldn't even narrow it down within family practice, I moved on to a job opportunity in rural Ontario, where I still live, to join a practice there, two other fellows in this practice, in a small town, an agricultural corner of Northumberland County, to work in an all-purpose practice with a primary care hospital right in our town where you could do anything and everything, and where our patients expected us to do everything, which suited me just fine until my first shift in the emergency department, when I realized right away I was in over my head. But I still settled into this community along with my wife, who turns out I married a farmer and a master gardener and a shepherd, and I never knew that. She never knew that. She became all those wonderful things, and we put our roots down in this community. It wasn't very long, though, Marcia, before my proclivities, my enjoyment of opioids manifest as a problem. Roots sowed earlier, but it blossomed soon after I got into practice. And within 4 or 5 years, I was in big trouble and sent off mercifully for treatment. And then my recovery began, and that informed the nature of my practice after that, with bringing in more mental health related work, more psychiatric related work, more addiction medicine, of course. I certified eventually in addiction medicine. And with that whole package of experience and training, once again, be careful what you ask for. I saw that the Ontario Medical Association was looking for somebody to come and start a program to help doctors who themselves had drug and alcohol problems. I resisted that ad. I resisted that call because I had built my practice and I had so much attachment to my patients and my community. But anyway, in the end, I applied. Sure enough, I was given the gift of that opportunity, and over to the OMA it was for me to build a service to do what I was hired to do, and then some, as it turned out. Who knew it? Doctors have problems beyond drug and alcohol problems. That doesn't surprise you, I know. And our program just went outwards and upwards and onwards to embrace the problems across a much greater number of domains that docs and their families and trainees too might have. Other professionals too along the way. And that was the bulk of my career, as it turns out. I was over 20 plus years there as the founding medical director of that service. I retired in 2017 because I felt the call of some other things, including writing all the stories of all of that, which I know is something that we're going to be talking about. And since then, I've been living this, well, I guess it was called retirement. My wife says it's anything but. I am busy with wonderful things, including the work related to that book and the mission I feel that I have in keeping with that. And I imagine you'll want to know more about that. So I'll stop there.
Yeah. I wanted to know what year you started the Physicians Health Program, because I joined it in 2002 when I finished my training and came back to Toronto from New York, but I don't know exactly when it actually started.
It was the summer of 1995.
Okay.
So, and I thank you for the support that I know that you provided for the folks who called us. That's how it works. We depended upon the goodwill, and still do, of course, of clinicians of all kinds to be there and be ready and willing, to help one of our own.
Yeah, I have a very tiny psychotherapy practice still, and I still have one person I see who is referred to me by the PHP, and I have another one who calls me every now and then out of the blue just for a check-in. So it's a nice connection, even though I gave up most of my private practice a number of years ago to do consulting work. But it's still a nice connection to have.
It is.
Yeah.
And I actually have remained connected to the PHP on a contractual basis and doing projects and stuff that's fun. But I still talk to doctors regularly in a more supportive kind of way. Probably every week, someone that has called into the PHP is given the opportunity, which it is for me too, to chat and just to answer questions and to be supportive and to continue in a different way the effort to help our colleagues, come to terms with the realities of their life and the challenges they have and learn how to overcome them and be great docs.
Yeah. It's not for the faint of heart, this profession, for sure. But I want to go back to you and talk to you about your book. Could you tell us when it came out and what it's called and what made you really decide, okay, I'm going to write a book about my experiences and my expertise?
Yeah, maybe I'll start there and then sort of fill in the other bits. As I said, I retired maybe a year or two before others might have, in part because I was feeling the pressure of wanting to tell some of the stories of my experience. I guess it began, it turns out I'm naturally a storyteller. I think many of us are. I was never actually trained as such. Narrative medicine was not a thing, but I've done lots of things that I wasn't trained for specifically, so that never stops me. Anyway, I would tell stories, when I was teaching, and usually it would be something that just happened or something I pluck out of my life that properly illustrates what I'm trying to teach to students and other learners. And my team knew that. Over time, our PHP clinical team grew wonderfully well. And towards the end of my stay there, they sat down with me and said, you're going to have to write down some of that stuff. We don't want to lose those stories. So I tried. And I've written some articles over the years, but I'm not a writer either, primarily. So I tried, and I struggled, to figure out even how to start. I follow a musician by the name of Rodney Crowell. I love his music. He's an American sort of rootsy kind of guy. And I saw on social media where he was involved with teaching something called a salon, and the salon was on how to write memoir. And oh my goodness, I looked into that, and the call of that, even though it put me way out of my comfort zone, was too much to resist. I signed up, I went. Mary Carr was also, and she's a memoirist at Syracuse University, so she's a great teacher. And I spent 2 weeks with other really amazing people learning how to get started on writing memoir. And that was in 2016. And I came back from that and think, okay, I'm out of here and I got to sit down and start writing. And that's what I chose to do. The scaffold for the book and its title came to me during this training that I had. The title is called Drugs, Lies, and Docs. And if you see the cover, the lies is in bright red. And the reason for that is because that was the title of the lecture that I gave to medical students year after year after year. I don't know, dozens and dozens, maybe hundreds. There is a story about how that title came about. I don't know if you want to hear it.
Sure.
Okay, this is it. It was one of the first times I gave this lecture. In fact, at the time, I think it might have been the veterinarians, because for a while we served that profession too. Anyway, the call came, would I come and teach at the veterinary college about substance use disorders in our professions? And I said, of course, that's one of the things I was hired to do. And she said, we already have the title. And she said, it's drugs, lies, and probably vets, if I'm remembering correctly. And I thought that was kind of weird. First of all, I wasn't normally told what the title of my talk would be. I make that up. And then I thought, that's kind of harsh, lies. But you might remember a movie called Sex, Lies, and Videotape. And I think it came out around that time. So they might have been inspired by that. Anyway, so I thought, okay, actually it makes sense. I can rewrite my lecture, my materials, redo my slides to riff on the idea of dishonesty and lies, because it's about addiction. And there is certainly a lot of that's woven throughout the addictive experience. So I inserted all these true and false questions throughout my lecture. I put them up on the screen in bright red letters, and that was the indication that we stop here. And I'll ask you a question like, such as substance use disorders are epidemic in the healthcare professions. Yes or no? Let's talk. Anyway, so I did that throughout the whole lecture, and it was designed to stimulate conversation and so on. And it worked well. Anyway, I get to the veterinary college in this case, and I do what I always do before a lecture. I stop and make sure that I won't need to heed the call of nature midway. And I attend the men's room, and I'm standing where men stand when they need to do that. And there's a poster right there at eye level facing me. I'm facing it, and in big letters it says, Dr. Kaufmann is coming from the Physician Health Program. And the lecture of his talk is Drugs, Lives, and Vets, Lives. Yeah, so I thought, I got it wrong, like I misheard. And so I'll gulp. Anyway, I decided to stick with the motif that I had put together, and they didn't mind. I'm sure they didn't notice. They didn't care, and it worked so well that I never let go of it. I did after that lectures mostly for doctors and medical learners, of course. So Drugs, Lies, and Docs was forevermore the title of my talk. And when it came to me that I could write my stories and at the same time teach about addiction and recovery generally and in the medical profession, that the scaffold was the lecture. And at those lectures, I'm now going on to think about your other questions. At those lectures, I would almost always brought someone with me who was in recovery, a medical student or a practicing doctor or maybe a resident or whoever appropriate for the opportunity to tell their own stories. So for a 1 hour lecture, I would do, 30 minutes or 35 minutes of my didactic stuff, my slides, and then they would give their talk. And of course, the students are riveted to them and they get through my part. And so, I learned early on how powerful the stories are in illustrating the teaching points and in teaching. So this book then represents a reproduction of that experience. It's set in the classroom in one narrative stream, and the A reader is a student in the classroom, and they not only get all the same didactic material that I presented then, but they get into my head too. So they can listen in on what's going on and where my thoughts are, and the wanderings and the various stories that I think are relevant by what I'm sharing with the students in a non-contemporaneous kind of way. The other narrative stream in the book is the testimonial part, only this time I'm the first person storyteller. And it's the opportunity for me to then share my own story of addiction and recovery, which is underlying the whole thing. It's why I was there in that job. It's why I was in the classroom with those students. It's why I wrote the book. It's why we're talking right now. It's turned out to be what matters the most to me. It's my mission, my ongoing mission of having lived a life of my own addiction and my own recovery. And so I'm getting to write about that. And then a little bit more as to why this book and why have I put it out there. Because I haven't held much back, Marcia. I've shared a great deal. I want people to understand the nature of addiction at a deeply human kind of way. And I also want them to understand the nature of recovery in a holistic kind of way. I want people to understand that recovery isn't even a good enough word, to describe how, and in my case, and in the case of most of the folks I've ever worked with, it's a glorious experience to live life. Learning how to fully realize who I am and to truly grow and mature as a human being and to stay well, certainly stay in remission as far as my substance use disorder is concerned, and flourish. So it's more than just getting better. And these days, I'm not too sure that idea is championed as often as it ought to be. And so I felt that was part of I do think it's part of my mission, but one of the main reasons for writing the book, along with even still others.
Yeah, it's a very important thing, and I think especially in this climate right now when so many laws are being passed and they don't seem very humane or humanistic, and they don't seem to have compassion for the person who is struggling with addiction. Now they're here in Ontario, they're talking about putting basically cops on the public transit who can arrest people for using, and they're talking in some provinces about forcing people into treatment. I think that was in Saskatchewan, being allowed to force someone to go to treatment even though they are not volunteering it. So the rules are very interesting these days, taking away these places where people can have safe injection sites, and like just taking away a lot of services. It seems to me counterintuitive, but I suppose it's politically expedient. But I was just wondering what you think of all that's going on right now.
Well, there's an ebb and flow to things. Much, I think, of what we see in the press and on social media and so on does stigmatize. And that is another reason I want to write this book. I want to humanize, not stigmatize. Also, I want to help individuals feel compassion. Thank you for using that word. Towards simply another human being who is suffering. The idea of quote unquote, I'll land on this comment specifically for a second, of forcing, as I say in quotes, folks into treatment is an interesting one. And not necessarily a horrible one. I'll say that. Forcing is not the right word. It's something that I have taken advantage of on behalf of doctors, in that highly motivating an individual to choose a treatment option as compared to some of the other alternatives is a scenario that is actually really effective. And in many ways, it was a strategy that we did use in order to encourage doctors into treatment. And here again, I'll be honest with you because I've told this story in detail over and over again, not only in my book, but every other opportunity I've had. Lots of folks approached me in the worst of my own opioid using days and expressed their concern and encouraged me to get help. And I told them all just to go away until finally one colleague came up to me out of the blue, totally unplanned as far as I could tell, met me in the hospital parking lot. And I approached him and said, you know, I was feeling a little burned out. I was just back from a March break and I was just trying to get my feet underneath me. I was also trying to detoxify myself, by the way, which an all-inclusive Caribbean resort is not a good place to detoxify oneself. Anyway, I said to him, would he help me cover my patients is what I meant, because I was a solo family doctor with a big practice. He said, no, he wouldn't do that, but he would help me actually with the actual problem. He says, I know about your drug use. We all do. Today's the day, he said. He pulled a piece of paper, literally a scrap of paper out of his pocket. And there was a phone number on it, written on it. And he said, call this number today, this afternoon, and I will check to see if you have. And if you haven't called, I will report you to the College of Physicians and Surgeons of Ontario, the regulator, the people who give us our licenses, right? Our registration. And I thought, okay, I really don't want that to happen. So I will this time do what he asks. And that was actually a call to a guy at the OMA, ironically, my future employer. It was just an informal referral to an addiction doctor in Toronto who did see other health professionals with a problem like I have. And he referred me for treatment, and he didn't give me a choice. They didn't give me a choice. They basically left me with the feeling, well, I had a choice, but I didn't like it. So I went to treatment, and they saved my life. Everything good that's happened in my life has flowed directly out of that place. And you could say that I was forced, let's just say really encouraged. And, you know, in doing some research on that idea subsequently, I learned that you can coerce, if I can use that word. It's also a strong word, but it represents what we're talking about here. Somebody into treatment. Someone might go into treatment with a substance use disorder when it wasn't really their first choice. And yet they do as well as anybody else. And it turns out to have been a good thing. So if there are strategies in society at large that make the decision to go to treatment easier to make and the alternatives more consequential, I'm behind that.
And now, let's pause for a quick word about my other podcast. Since I was a kid, I've loved watching movies. As a psychiatrist, I'm blown away by how film touches us at our core, deepens our self-knowledge, and can improve the human condition. I wanted to let listeners know that I've started a new podcast called Real Mental with Dr. Marcia Sirota. I'm going to be talking with directors, writers, actors, and critics to help people figure out their lives by getting to the truth about mental health on the big and small screen. Some recent films covered are Anora, Emilia Perez, Will and Harper, and The Last Showgirl. Please subscribe to Real Mental on Apple Podcasts or wherever you listen to podcasts. That's very interesting because I've worked with a lot of people who are dealing with substance use issues. I've done a lot of assessments for people in the nurses' health program here and, done a lot of assessments on people who were in a treatment center at the time of the assessment. And so I've spoken to a lot of people, and what you say reminds me of involuntary admission for someone who's suicidal and who's saying, yes, I want to kill myself, but no, I don't want to go into the hospital. And we put them in the hospital anyways for their own safety. So I understand what you're saying, but I've also seen people who've gone unwillingly into treatment and said, nope, and come out and immediately started using because even though they might have, thought what was being said was interesting or meaningful, they were just mad and spiteful and saying, nope, if you're forcing me, I'm not interested. And they immediately started up. And so I'm not sure. I'm not sure where I land on that one.
Yeah.
I like the idea of free will and autonomy, but I understand what you're saying as well and how well it worked for you and what the research says.
Yeah.
So,
The additional factor that I had, I suppose, in my favor, and by that I mean it just made it an easier concept to be with, was the fact that now, you see, this population that I'm working with or was working with are health professionals. It's a real subset, right? It's not a general population. In my general population practice as a family doctor doing addiction medicine, well, you'll recognize the principles of just understanding what a person's needs are, where they happen to be at the moment, where they are along a continuum of willingness to change, stages of change, trying to meet them there, nudge them a little further along. All of those good things form a relationship, work within those relationships. I get all that. I respect all that. But I was working with doctors who were going to work and treating patients while they were drinking, while they were using, which is what I did, to some detriment. And I couldn't see that happening. So if we could shoehorn somebody into treatment and A, help them get better, B, protect them from their own risk, protect their patients from risk, protect our institutions from risk, protect a population from risk, it's only upside, to help those folks in. And if they chose not to stay, they could leave. They were not involuntary patients. They were never involuntary. They just had to make a choice, the least bad choice at the moment.
yes. And really, now that you're saying that, I'm thinking about my work with the Nurses Health Program, the NHP, and how these were nurses who had nursing college complaints and their license was on the line. And by agreeing to go into treatment with the program, they could perhaps spare their license. And our treatment was very much about, getting them back on track if
That's
possible,
right.
but not returning them back to work until they were safe to
Right.
practice. They were
Right.
safe to their patients and to the community. So I do understand what you're saying. And I wanted to ask you, actually, now that you brought up, is there something different about somebody in the medical field versus the layperson or non-medical person and addiction?
Okay, let me say yes and no. Or it depends. It's the kind of answer that, it's an interviewer may or may not want. It's not necessarily black and white.
I'm a psychiatrist. I live in gray.
Yeah. Yeah. So the first lesson, when I taught my book, The Reader Will See, I am teaching about the nature of addiction, of substance use disorders, using those terms synonymously in this case, generally. If you pull out our DSM and look at all the addiction criteria, there's nothing in there about whether you're a doctor or a woman or a male or any race or anything. It's independent of all of that. They're clinical criteria. And I think that the illness, if I can call it that, and not everybody would, is manifest much the same in anybody who's experiencing it. The individual variation, individual details, of course. But at the end of the day, these are conditions that are diagnosable for anyone according to standard clinical criteria, standard history, standard physical, standard lab work, and we put together a diagnosis as we do for anyone else, whether it's psychiatry or general medicine. So the condition, I think, was manifest in me as an individual and everyone I ever helped as an individual, much in a similar fashion, identifiable as a condition as such. So, all right, that's the sameness. What's different? Well, we all bring ourselves to the world differently, and we bring whatever burden it is that we bear, and most of us have one or another, some sort of sack of load on our backs, and we bring that to the world and to our experience in a unique way, an individual way. For doctors, it's bound up I think, in our identity, who we see ourselves to be, what our role is or what we believe our role is in society, how we see ourselves as helpers and caregivers, not care receivers, how we are enculturated, if that's the right word, to feel, on the one hand, empowered and as people who are leaders and people who are depended upon to do really, really important work, and we believe in it. And we have tons of concern and compassion for the folks that we're serving. And we put those needs up above other things, especially our own personal needs. I think we're trained either overtly or covertly to do that. It's then woven into our sense of who we are. And then we pass that along to the next generation like a meme. And it's part of the culture. And for many of us, we felt like imposters in that culture, especially at the beginning. Later on, we kind of accept it. And it's really, really hard. I speak generally, I speak specifically. Everything I say to you, I've lived. It's really hard to feel oneself slipping into the throes of a condition like addiction, and how that impacts one's behaviors, my behaviors, one's values in negative ways that are just unthinkable. Yet they're happening. And the shame and the guilt attached to that is overwhelming. And it drags us down and it forces us deeply underground. It makes it really hard to say, I don't feel well, I need help. They don't do that, Marcia. I don't know what your experience has been, but when I answered the phone at the PHP to speak to these docs, it wasn't never, but it was unusual that they were calling out of the blue entirely on their own. There was usually someone or some set of circumstances that were compelling it. And working with these callers, working with these amazing people, doctors, caregivers, intelligent, motivated people, compassionate people on one side, and wounded people on the other, deeply wounded all kinds of ways prior to their use of substances and as a result of their use of substances. Helping them reconcile that was really tough. And therefore, I had to learn how to be there for those folks. I had to train my team how to be there for those folks, how to respect all sides of who they are. And we also leaned towards treatment opportunities for them that did the two things at once, that treated their substance use disorders as though it were anyone, any patient in society, and layered on to that somehow this separate and somewhat more special understanding that as healthcare providers, there were other issues at play. And they had to be honored and recognized somehow. I was able to experience that from day one in treatment. And I tried to make sure that everybody I ever sent to treatment had the same kind of opportunity. So in essence, they're getting a twofer kind of experience, if that makes any sense to you.
Yeah, and I think that's really important because I do think medical professionals are a distinct population for all the reasons you said, and how much our identity is tied up with our profession, and how that plays into guilt and shame and hiding and lying, if we have a problem, and the unwillingness to seek help because of that guilt and shame, and the disconnect between the identity of who we think we should be and who we see ourselves becoming or being. So yeah, I think it's important to acknowledge both of those parts.
Yeah. And so to do that, you see, when these folks would come into treatment, we put the doctor part mostly aside. We do honor it. We do look at special issues like access to drugs and returning to work eventually and stuff like that. But mostly we focus on just getting a grip of who we are as human beings and learning how to remember that, who we are as spouses and who we are as family people and who we are as friends or whatever other elements of ourselves make up who we are as human beings. Addiction does allow us the opportunity, addiction treatment, to sort of peel back the layers on those kinds of considerations and help people find themselves again. And then, when the time is right, and not until the time is right, we bring back or weave in who they are as healthcare providers, especially as we approach the return to work, because that's a challenging time, but also a really important time. And I do want to say, and I always said this to the docs, and still do, that I have the opportunity to speak to, they almost all do go back to work, no matter how bad it was. And most of them even go back to work in the same place they left, which is good news. But not until it's safe, and not until we're able to go on that journey with them. And we designed the program to do that, to be with them as support and advocacy and in a monitoring capacity. And then massage that return to work opportunity exquisitely carefully, very incrementally, staying very close so that if there was any risk or any slippage, if I can say that, we'd be on hand and help them through that, help them away from the workplace and away from patient care temporarily if need be for safety, and then back at the right time. And the other thing too, Marcia, I'm wandering off maybe your original question a bit, although it is relevant in terms of what happens in the end. I mean, I worked in the community treating people with drug and alcohol problems routinely, and it wasn't a highly rewarding experience. Relapse rates tend to be quite high. And that's understandable. Addiction is a chronic relapsing disorder by definition. But in the subset of healthcare providers who have the experience that they have and who are followed by programs like mine and the nursing health program that you've referred to, which is also, by the way, I don't think I'm being too inaccurate to say that it's largely patterned on the PHP experience, as ours was patterned on the same elsewhere. It is intensive, and as I say, we do stay close to these folks, and we follow them for at least 5 years. That's a long time to be close by and to follow. And they do really, really well. The first year or two, it's a bit touchy. That's when the transition is happening. 28 days or 6 weeks or 2 months in treatment doesn't cure it. It gets us to an early remission and helps us get things started. It's everything that happens after that that makes the difference. And it's the time spent building recovery capital, we call it, through all the various self-care things that we're taught to do, and the mutual support and professional support and peer support, all those things. Over time, in a chronic disease model approach, gets us to the happy outcome of nearly 90% sustained remission after 5 years. That's pretty darn amazing. Are doctors so special as a subspecies that, they're the only ones that can get there? No. But because they're doctors, because they're in a safety-sensitive profession, because we're taking such care, they are exposed to this approach that really embraces the idea of the chronic disease model. And that's, I think, why we're successful and why they're successful. And if that makes us different, then so be it.
Yeah, I think it makes doctors lucky and the nurses, because they get more ongoing care. And I think it's the ongoing care that really counts, right? It's that the follow through. Because, addiction is, as you say, a very difficult and chronic condition, and relapse is the norm, not the exception. And if you have that ongoing care, and if the person who's dealing with the addiction knows that they have all this support, I think it makes all the difference in the world. And as your statistics show, like, your statistics are kind of the opposite end of the spectrum of the typical recovery, which might be around 10%, right? You're like, you have the 90% where the average person might have 10%. So it's, that ongoing care, it sounds like it's really key.
That's why I felt so fortunate to work with this population. The rewards were really much greater than any other experience. I'll add one other word into the conversation, though, Marcia, which also I think helps with sustained remission and embracing recovery, and that's accountability. Again, as a safety sensitive worker, I mean, all of us are accountable, no matter what our various different roles in life are. There's accountability built in. But as a safety sensitive worker, as a doctor or a nurse or what have you, we are highly accountable to our patients directly, to a population at large. And it was my observation that sometimes we forgot that. We did our training, we got our licenses, we got our specialties, we went to work, thrown in the deep end, and just worked away, and kind of forgot that this was a privilege, not a right. So that's something that we need to remind our folks, that the good news, this is really good news, and it's destigmatizing. Our professions, medicine, nursing, other healthcare professions, they welcome us, flaws and all. I think many of them, if they're enlightened, recognize that those flaws and that lived experience, if anything, just makes us better clinicians and compassionate healthcare providers. It does not rule us out. And once upon a time, it might have. And if you listen to some of the stuff that you mentioned earlier that goes on in society, you might think, okay, if they find out, I'm done. And it's not true. And that's another reason I wrote this book. And it's another reason that I continue to tell my stories and do what we're doing right now. Folks need to know it's not true. There's a place for us in society. Generally, there's a place for us in our professions, as long as we're well and prepared to be accountable.
That's a wonderful note to end the formal part of our conversation on. And I love the word accountability, and I use it a lot in my practice as well. So it's a theme that is very near and dear to my heart. But I'm going to ask you my last 3 questions now, Michael. I'm going to ask you first, where can people find you and find your book if they're interested in reading your book or learning more about your work?
Thank you. Thanks for the opportunity to share that. The easiest way is just go to the book website, my website. It's just imichaelkaufmann.ca. And the hard part is spelling my name right. So it's I and then Michael, Michael, and Kaufmann is Kaufmann, 1 F, 2 N's, .ca. And all the book information is there, and more stuff too, including more stories, because here's the thing. A funny thing I found out. When you get the writing bug, it's hard to shake it off. So I thought I'd write this book and put it out in the world and be done with it. It seems there are a lot more stories to tell, and I want to write them. And so my publisher has said, okay, you got to write those things and we'll pop them on the website. And so you'll find those there as well.
Well, I think you started answering my question. What are you up to these days?
I'm up to a bunch of things. I think I referenced before that I'm hanging around the PHP. They've given me the title of Medical Director Emeritus. Sounds grand, doesn't it? But what I say is it just means I won't go away. I retired, but I won't leave. So I still help out in various ways. I still teach when I have the opportunity. And I talk to doctors all the time, which I think is an honor. I have other projects as well. I'm on the board of directors of a local West Bend arts festival. It's all about music, and I play music with friends. So music's a big part of my life. The book is the biggest part of my life right now, and promoting it. The messages that we've talked about and other ones. I wrote another chapter related to this book on the subject of forgiveness in an anthology just published. It's entitled When We Forgive. And a little promotion for that. You can learn more about that on the book website too. And it's giving me the opportunity to speak to folks like you. And something that's happened that's sort of evolving is the ongoing teaching, which is also book promotion. But I'm doing that now in a conversational way, in a fireside chat kind of format, where the interviewer from whatever organization has invited me to come and share. They read the book and they develop their questions in keeping with their learning objectives, be they professional or community or otherwise. I've even gone into prison to do book clubs for inmates and do book club around my book with their all different audiences, medical and non-medical. And we sit and we talk and we riff on this and that from the book, and then people in the room ask their questions. Could be 300, it could be 12. And I'm doing these a lot, and I'm enjoying them a great deal. So I've had that opportunity as well. These are the sorts of things I'm doing these days. And as I said, my wife says I'm not really retired. But if this is work, I'm pretty darn lucky.
Yeah, it's what do they say? If you're doing what you love, it doesn't feel like work, right?
You bet.
And I'm going to ask you my last question now, which is, what is your call to action for the listener apropos of our conversation? Something they could think about or something they can put into real world action?
Well, you asked me to put myself in the place of other people. I'll start with where I am, and it flows from this conversation that I'm doing this out of a sense of mission. I really am. I have this lived experience. I survived. This addiction and the recovery that followed, as I've said, has taught me a great deal, is still teaching me. But more than anything, I'm left with the feeling of a sense of responsibility, even a sense of obligation to share all of this information and lived experience. I could have just quietly gone off into play more golf. I do play golf too, by the way. I love that. But I'm not living a golf lifestyle, at least not yet. So my personal call to action and personal mission is to tell all of these stories, pull the curtain back on what addiction is, let people know recovery really is, help humanize and destigmatize. So on the other side, I would ask folks to open their minds. I would ask folks to seek out information about what addiction really is. I would ask folks to open their own hearts and understand better who they are as people, to read books like mine, and there are many others, to know themselves better and their family members better. Indeed, when I do some of these talks, people come up to me and say, I have a family member with this or that problem. Thank you for this. I want them to read it. Or, surprising to me, some people approach me and say, oh, that was really insightful for me. I've learned something about myself. I don't have any drug or alcohol problems, but I really learned something about myself. And I actually don't even know what it was. We don't have time enough to talk. So, I ask people to, again, open their hearts and minds to this kind of messaging. Read my book, read others, listen to your podcast and others when they might not have first thought something about addiction was all that interesting. Or for some reason, they might have felt a resistance to looking at something like that, to ask themselves why and take a chance.
That's wonderful. Well, Dr. Michael Kaufmann, thank you so much for coming on the Ruthless Compassion podcast today. It's been wonderful talking to you.
Thank you so much for the opportunity. I've enjoyed myself as well.
This is Dr. Marcia Sirota. Thank you for listening. Please leave a review and your comments wherever you listen to podcasts. And don't forget to sign up for my free newsletter at marciasirotamd.com, where you'll learn about upcoming online events as well. Also, we love getting referrals from our listeners about future podcast guests. So please email us at info@marciasirotamd.com.